Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the first in a series of 3 CMEO snacks titled Pathogenesis of Psoriatic Arthritis, a broader understanding to inform next steps. The CMEO snack series is supported by an unrestricted educational grant from Bristol Myers Squibb Company. I'm Alan Gabowski, professor of medicine at Weill Cornell Medical College, an attending rheumatologist and co-director of the Clinic for Inflammatory Arthritis at Hospital for Special Surgery in New York. I'm joined today by my dermatology colleague, Dr. Anthony Fernandez, Director of Medical Dermatology and the W.D. Steck Chair of Clinical Dermatology in the Departments of Dermatology and Pathology of the Dermatology and Plastic Surgery Institute of the Cleveland Clinic in Cleveland, Ohio. Welcome, Tony.
Thank you, Alan.
Today's activity is eligible for ABIM Maintenance of Certification credit and also as a CME for MIPS improvement activity. Once you complete the activity, please provide your ABIM ID and birth date when completing your evaluation, and CME Outfitters will submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. Over the next 90 days, actively work to incorporate improvements in your clinical practice from this presentation. Complete the follow-up survey from CME Outfitters at the end of that time, and CME Outfitters will send you confirmation of your participation that you can submit to CMS, attesting to your completion of the CME for MIPS improvement activity. So to frame the discussion today, let me review and state our learning objective, which is to describe clinically relevant pathophysiologic processes that contribute to the development of psoriatic arthritis. So, Tony, psoriasis, arthritis, psoriatic arthritis, is this something that begins in a dermatology office or a rheumatology office?
That's a great question, Alan. So, as I'm sure you know, and many of the audience members know, psoriasis is a very common chronic immune-mediated disease. It is estimated to affect 2 to 3% of the entire US population. And about 30% of all patients with psoriasis will develop psoriatic arthritis at some point during their disease course. And although the psoriatic arthritis may begin prior to the onset of skin lesions or coincident with the onset of skin lesions, the most common scenario is that the skin lesions will present prior to the onset of joint symptoms. And that really does put dermatologists and even primary caregivers in a unique position to often be the first clinicians to detect the onset of psoriatic arthritis and to recognize that these patients need a definitive diagnosis and either do that themselves or hopefully refer to a rheumatologist like yourself. So I do think it's important for dermatologists and primary caregivers to recognize some of the clinical domains of psoriatic arthritis. And those domains include some skin manifestations, of course, the typical psoriatic plaques that we recognize in patients with psoriatic disease, but also the nail manifestations of psoriasis. That's known to be a risk factor for patients with psoriatic arthritis and can often be present in patients who have psoriatic arthritis. And then some of the different clinical manifestations in and around the joint spaces: enthesitis, dactylitis, or swelling of an entire digit, axial disease, and even peripheral arthritis, which is, as you know, one of the most common patterns, if not the most common pattern of involvement. So luckily, we've learned a lot about the pathophysiology of psoriatic arthritis over the past several decades. And Alan, I was wondering if you could shed some light on our current knowledge about that pathophysiology.
Well, I'll try, but it seems that the more we learn, the more we have to learn. You've described the clinical domains, and the challenge then is to relate the clinical domains, of course, to the immunology and pathophysiology of a disease which probably starts in the skin, but perhaps does so under the influence of other areas in the body and the immune system, such as the bone marrow and the gut. A lot of extensive research being done now, in particular, about the influence of the microbiome on what goes on in the rest of the body and the other organ systems. And certainly we have the involvement of B lymphocytes that may have been honed in the bone marrow and then directed to the skin where they influence the immunologic milieu. The changes in the skin are also reflective of what may be seen in the enthesis, with the mechanical stress or trauma affecting perhaps IL-23 and the various type 17 lymphocytes. There may be involvement of osteoprogenitor cells under the influence of interleukins as well. And then within the joints, we have this careful orchestrated mechanism of the antigen-presenting dendritic cell and the macrophage activating lymphocytes and involving osteoclasts to affect the structure of the joints, all under the control of interleukin 23, tumor necrosis factor, interleukin 17, the interplay of rank ligand, all of which may result in the inflammatory changes that we see both intra-articularly within the joints, as well as at the enthesis and other sites as well. So the pathogenic pathways are multiple. The pathogenic pathways are complicated and not fully understood at the present time, yet interesting to try and tease out as targets of therapies that we'll discuss in later episodes. But Tony, we also know that in addition to the clinical domains that you've mentioned, there may be other comorbidities common in psoriatic arthritis. So what comorbidities do you see in your patients with psoriasis who may also progress to psoriatic arthritis?
Yes, another great question, Alan. And the comorbidities that are seen in patients with cutaneous psoriasis are quite similar, if not identical, to the comorbid diseases that are seen in patients who primarily have psoriatic arthritis. And I think it's interesting that you mention in terms of the pathophysiology that inflammation may start in one organ and then spill over or initiate inflammation in another organ system. So I guess it's no surprise that we see active inflammation in numerous organ systems in patients with psoriatic disease. For example, patients not uncommonly have ocular inflammation in the form of uveitis or iritis. They obviously can have inflammation in the skin or the joints in the form of psoriasis and psoriatic arthritis. And there's definitely a link. Patients with psoriatic disease have an increased risk of inflammatory bowel disease, both Crohn's disease and ulcerative colitis. The other thing we know about patients with psoriatic disease is they often have comorbid conditions that are associated with an increased risk of cardiovascular disease. Patients are often obese. They often have glucose intolerance or meet diagnostic criteria for diabetes. They often have abnormal cholesterol panels and dyslipidemia. And they often have other cardiovascular comorbid diseases such as hypertension or even peripheral arterial disease. And individually, these all add up to a significant increased risk for cardiovascular disease, especially in patients who have moderate to severe psoriasis.
And the same in patients who present with inflammatory joint disease as well, I would point out. Tony, in your first remarks, you commented about psoriasis, which you see, and then picking up patients with joint involvement. Are there any kind of screening tools that you use or that you can mention or go over quickly for our audience?
Yeah, there are actually a number of validated screening tools that can be used. And these are actually very important to know about in the field of dermatology and primary care because, as you know, Alan, many physicians within our specialties are not very well educated about the clinical manifestations of psoriatic arthritis and really how to screen based on discussing symptoms with patients and doing a physical examination. However, we do believe, as we mentioned earlier, because so many patients will have the skin disease prior to the joint disease, we really are in a particularly interesting situation to be the first caregivers to recognize onset of disease. And it is critically important if patients are developing psoriatic arthritis to make sure they get a diagnosis promptly so that they can be initiated on the therapies that can hopefully inhibit permanent joint damage. And so a number of validated screening tools such as the PEST, the PACE, the TOPAZ, the ERP, and the PASQ have been developed and are available to use in patients who have psoriasis as a screening tool. And these usually consist of a short questionnaire that can be given to the patient even in the waiting room before the clinician even walks into the room to start the encounter. And based on how patients answer these questions, they're assigned points. And if they meet a threshold number of points, then that suggests they are at significant risk for having developed psoriatic arthritis and warrant referral to a rheumatologist like yourself to help make a definitive diagnosis about what is going on with their joints. So Alan, when we do refer patients to you because we're suspicious about them having psoriatic arthritis, what are the clinical manifestations that you look for to make that diagnosis?
Well, you've already relieved me of one burden, which is looking for psoriasis, because the patient that you send to me is known to have psoriasis. So now my challenge is to look for the signs and symptoms of inflammatory joint disease. And those would be joint stiffness, morning pain, morning tenderness, joint pain that improves with activity rather than is worsened by it, swollen and tender joints, dactylitis, enthesitis, inflammatory back pain, ocular symptoms of uveitis. And then I'm going to be, as part of my workup, doing imaging studies of the affected joints to look for changes there as well. I'll be looking for disease activity with markers such as the erythrocyte sedimentation rate and the CRP. I'll be looking for a negative rheumatoid factor. I'll be looking for a negative anti-CPA because psoriatic arthritis is a seronegative disease in nearly, but not all, instances. And then my physical exam will be looking for things like nail changes, oncholysis. It may appear to be fungal, but in fact it's not. I'll be looking for the sausage-shaped digits. I'll be looking for inflammation at the insertion of tendon into bone, the so-called enthesiopathy, most notably seen at the Achilles tendon. And I'll be looking for any other manifestations of inflammatory disease, such as tender and swollen joints. I won't be fooled by thinking that the joint pain has to be near the sites of skin lesions, because we both know that you can have both a geographic and temporal disconnect. And by that, I mean you can have skin lesions over joints that are not inflamed, and you can have joint lesions that are far removed from skin lesions that are inflamed. And you can have the joints active when the skin is quiescent. You can have the skin active when the joints are quiescent. And all of those kind of make it a little bit more challenging to make the diagnosis. I've alluded to some of the laboratory tests I'll be ordering. I might get a HLA-B27 if the patient is presenting with arthritis and if I'm suspecting psoriatic arthritis, particularly of the axial variety. I might get an arthrocentesis and synovial fluid analysis if the patient has a large joint swollen effusion. And I've also alluded to imaging studies that are going to be part of my workup as well. So the workup is going to be looking more for the absence of things rather than their presence. And all of those things put together in a patient with psoriasis is going to help me make the diagnosis. In addition, I have some help from what's called the CASPAR criteria, the classification criteria for psoriatic arthritis. Now, we have to be careful when we use classification criteria diagnostically, because classification criteria were devised to come up with homogeneous populations of patients to enroll in clinical trials. They are not meant to be diagnostic, but nevertheless, they're often used as a guide. So if I have a patient with inflammatory musculoskeletal disease, spondylitis, enthesitis, and or arthritis, with evidence of psoriatic arthritis, with a current by history or family history, with psoriatic nail changes that I've mentioned, with a negative rheumatoid factor, with dactylitis or radiographic evidence of juxtaarticular new bone formation. I can add point values to each of these domains and come up with a score which helps me give a great probability that what I'm dealing with is psoriatic arthritis rather than just joint pain in a patient with psoriasis. So I guess that leads to another question, Tony, which is we also see the words moderate, severe, mild thrown around. How do you begin to think about psoriasis on the spectrum of mild, moderate, and severe?
Yeah, there are different ways to assess the severity of psoriasis in patients. So when we think specifically about, I guess, severe psoriasis, one way to decide a patient has severe psoriasis is with an objective scoring tool, such as the PASI, or the Psoriasis Area and Severity Index. And using that assessment tool, a PASI score of greater than 12 is considered to be severe. And a PASI takes into account not only the body surface area involved in different regions of the body, but also the degree of erythema, the thickness of the skin lesions, and the scale of the psoriatic lesions in each of those different regions. And a PASI score of 12 is actually important because it's often the threshold PASI score that is utilized in phase 3 clinical trials to determine if a patient has severe enough disease to meet inclusion. Another way to assess severity is simply by looking at the overall body surface area that is involved with psoriasis in the patient. The National Psoriasis Foundation has actually come up with definitions for mild, moderate, and severe, with mild disease being anything less than 3% body surface area involvement, moderate disease is 3 to 10%, and severe disease is anything more than 10% body surface area involved with psoriatic plaques. And you can think about 1% of your body as being about the surface area of your palm, including your thumb. So really, it doesn't take that much psoriasis to qualify as having severe disease. If you have just 10 palms worth of psoriasis on your body, you qualify as severe disease. And that's actually important because that severe disease has been found in numerous studies to correlate with a significant increased risk of cardiovascular disease and even mortality. So you don't have to be covered head to toe in psoriasis to be at risk for significant comorbid diseases or even mortality in the future. Now, with all of that aside, there are some anatomic locations that, when affected by psoriasis, may qualify the patient as having severe disease, even if they have a minimal amount of actual psoriatic plaques on their skin. So for example, the face or the genital areas, a patient may only have 1% body surface area overall on their entire body, but if that 1% is involving the face or the genital areas, it can significantly impact the patient's quality of life. On the face, it may lead to significant embarrassment, a significant amount of psychological distress. It can affect their ability to have relationships or even to be hired for certain jobs. And similarly, in the genital areas, that can have a significant psychological impact and affect their ability to have intimate partners in the future. Additionally, if patients have involvement of the palms and soles, again, there may be a limited amount of body surface area that is involved. However, that involvement of the palms and soles can lead to physical impairment, it can lead to physical pain, and it can really affect a patient's life in a severe way. It can inhibit them from participating in recreational activities. It can keep them from being able to adequately perform their functions at work, and in severe cases, even affect their ability to perform some activities of daily living. So Alan, what about severe, mild, and moderate psoriatic arthritis? How do you qualify patients as having one of those different severities?
When we talk about severe psoriatic arthritis, we're generally talking about people who have severe erosive disease. A pathognomonic form of radiographic finding would be the so-called pencil and cup deformity of the hands that we see, or changes in the spine consistent with those seen in established axial spondylolithropathy. We also see significant elevation of the acute phase reactants like the SED rate and the CRP that are attributable to the inflammation of psoriatic arthritis. And then there may be long-term damage that interferes with function of the joints involved, as well as you've already so nicely outlined, major impairments in health-related quality of life. We may see changes in the fingers, the nails, the hands, as the disease has been allowed to consist and persist over time, even though the functional limitation of psoriatic arthritis may only be at a couple of sites. It leads us to the recognition that we're dealing with an accelerated disease rather than a slowly indolent one. So it's both time and activity that leads us to use the modifier severe in patients with psoriatic arthritis. Another challenge that we have is trying to differentiate among the phenotypes of psoriatic arthritis. And perhaps the two major ones are the peripheral and the axial. And then we have the challenge of differentiating axial psoriatic arthritis from axial spondylolithropathy, because both are part of the spectrum of spondyloarthritis. There are overlapping features, but there may be different genetic, clinical, radiographic, and prognostic characteristics. For example, the genetic marker HLA-B27 occurs less frequently in axial psoriatic arthritis, but it is a genetic risk factor for both diseases. Patients with axial psoriatic arthritis tend to be older than those with idiopathic axial spondyloarthropathy. It tends to be less symptomatic and have the distinct radiographic features I've already outlined. But part of this is also complicated by the lack of universally accepted definition of axial psoriatic arthritis, and thus the true comparison of these two diseases is really quite challenging. So let me summarize our discussion with our SMART goals for today. We need to recognize that psoriatic arthritis can present in either the dermatology or rheumatology clinic, depending upon the primary symptom. We need to be able to accurately diagnose psoriatic arthritis by utilizing simple and easy to administer screening questionnaires. And then we have to screen patients with psoriatic arthritis for common comorbidities. Well, this CMEO snack is one of 3 parts in the series, and we hope that you'll take advantage of all of the short and focused activities in the series. These activities, as well as a wide variety of others on inflammatory disorders, are available on the CME Outfitters Psoriatic Arthritis Education Hub for both healthcare providers and patients, and the link is shown on your screen. Again, if you want to collect credit for today's activity, please click on the link and complete the post-test and evaluation online. Be sure to fill in your ABIM number if you want to obtain maintenance of certification credit, which along with your date of birth will be submitted to the ABIM, and you can print out your certificate or statement of credit immediately. Well, Tony, let me thank you for joining me today, and thank you to the audience for your kind participation. I hope the presentation gave you some new ideas and strategies for recognizing the features of psoriatic arthritis, and you'll be better equipped in the patients that you see next so that you can take the next step in treatment to mitigate joint damage.